I would like to welcome everyone to the conference. This is the MD Anderson Cancer Center. Here we go. Hang on, there we go. Integrative Diagnostic Medicine Case Conference for April 24th, 2020, and this is special edition, Lunch and Learn, Adventures in Neuro-Oncologic Diagnostic Medicine. Really happy to have everyone online. I think everyone's microphone is muted to cut back on the background noise. Please feel free to use the chat function to communicate. You have answers to questions I ask, et cetera, et cetera. Okay, 35th Annual Houston NP Review will be coming up. Yeah, let's do a warm-up. We always do a warm-up in the conference. Okay, we're going to start off with Kindergarten Neuropathology Challenge. And I like to do this because I think it's something that probably 99.9% of people listening will be able to get. Okay, you ready for this? What I want is a diagnosis, okay? And don't be intimidated by the fact that I'm calling it kindergarten. You know, that's all relative. No pressure. All right, here we go. What's your diagnosis? Anyone make a diagnosis on this? This is like the best case, the best example of the entity that I have. Yes, Darshan Trivedi, IDMCC Neuropathology Fellow, right off the bat, pseudomonas meningioma. It is indeed a pseudomonas meningioma, WHO grade 1. Notice that I'm using the Arabic, not the Roman numeral, because that's the way it's going to be going. And I'm going to address that a little bit later in the conference. Let's bump it up for our next warm-up. Let's do a neuroimaging challenge. And I'm going to make this a 201, just one step up from pseudomonas meningioma. Are you ready? Here we go. What's the diagnosis? Now, what I would like, this is going to be hard for you to actually type in, because I would like for you, just everyone in your mind, look at this and think of all the information that you're getting from these images. So there's one patient, and you've got a bone windowed CT, and then 3 MR images. And what is everything that you know? All right, Dr. Cathcart says intraosseous meningioma, so that's good. Dr. Harbs, I had Harbs, atypical meningioma. So that is correct. So it's atypical, it's intraosseous. What's the anatomic location? That's another thing that we have. What side is it on? See, it's just all of this information is what I'm going for, okay? All right, so cut to the chase. This is a right sphenoid intraosseous hyperostotic atypical meningioma, WHO grade 2. All right, let's go through this. Number one, it's on the right side. You can easily get right side from 3 of the images. It is the sphenoid. This is a very characteristic location of intraosseous meningiomas. We see this a lot. It is hyperostotic because the bone is thickened. You look at the sphenoid bone, markedly thickened, and you can see this. Look at the middle panel. You can see my cursor. Also, look at these spicules radiating intracranial, radiating into the extracranial soft tissues, and also dense calcification, deposition intraorbital. So this is 3 different compartments involved by this meningioma. All right, so it's hyperostotic. Atypical. How do we know it's atypical? Look at the upper left panel. If you look at the upper right first, the coronal, that's almost a smooth convex border, and with kind of a fat dural tail. I could buy that for a grade 1. Absolutely, 85% chance. Dr. Harb is correct. She says mushrooming sign here on the parasagittal. Look at this lumpy, bumpy, all right, surface. All right, that's not the beautiful convex that you would expect. Now, the mushrooming sign is not 100% pathognomonic for a grade 2 or grade 3, but it is a red flag saying you better consider it. And if you're called to frozen section, you're going to be looking at this with an eagle eye. I mean, your radar has gone up to look for mitotic figures and other atypical features. Okay, you got that? So that's the sort of thing that we're looking for. That was a good challenge. Okay, new conference feature. I love to introduce new conference features. As everyone who's attended this conference for a while knows, sometimes they actually will be repeated. It depends on the material. Other times, it's like one and done, a one-off phenomenon, as they say. All right, I'm going to call this new conference feature Mysteries from the Medical Record. And, my gut feeling is that we're going to be doing this a fair amount. And the point is, detail is important. Your product is important. For diagnostic radiologists and for surgical pathologists, clinical surgical pathologists, your report is you. That's it. That's your product. That's what you are doing. And that is what is telling the primary care physician what they need to do to adequately care for the patient. And when your report is full of errors, it doesn't look good. That's your product. That's a sloppy product. But we can have some fun with this while we're emphasizing that point. Mysteries from the medical record, all right? And I'm going to call this, let's see, hang on just a second. We click here. There we go. Okay, can everyone hear me? Mina says she can't hear me. Would someone, Ann, can you hear me, Ann? Ann Kwan, can you hear me?
Yep, I hear you.
Okay, good. Thank you, Ann. All right, here we go. Neuro-oncology mysteries, Volume 1, Case 1. The curious case of the conscious lesion. This is one of the strangest I've ever encountered, I'll have to tell you. History of the present illness. The patient underwent recent CT scan of the head and neck as part of the staging workup for squamous cell cancer of the tonsil. This revealed a conscious enhancing lesion in the deep right parietal lobe. What is it about the deep right parietal lobe that it would actually have a conscious lesion? This is a mystery. There it is. For those who can't read the print, this revealed a conscious enhancing lesion. All right, what should it have been? Any guesses as to what this really is? Yes, Gaussian intravenous contrast. Dr. Cathcart, fetus intracerebri. I love that. Oh my gosh, that's creative. Fetus in situ truly would be a conscious lesion. Oh my goodness, I really wish that this was an incidental finding of fetus in situ. As it turns out, it's more mundane. The patient actually had a contrast enhancing. Yeah, Dr. Harb got this right. It was contrast enhancing. Okay, I want to say to Dr. Sahara Cathcart, other neuropathology fellows, if you run across a fetus in situ, especially an incidental one like when you're out in practice, I want you to shoot that one to me. I'm still waiting for my first, right? All right, and I will present it. Dr. Cathcart says done. Okay, let's do another one. This is still volume 1 of these the mysteries. Case number 2, the curious case of the brain with a heart. It's kind of hard to figure that one out with no further data, isn't it? All right, here it is. This is the MRI, brain with and without contrast. The patient's history was multiple myeloma and intracranial myocardia. That is amazing. What is it about myeloma and myocardia in the brain, or at least intracranial? I wonder if it could be meningeal myocardia. What do you think? Any guesses? Anyone a guess? I think I have it. There it is, writ large. Multiple myeloma and intracranial myocardia. That's really a strange one. Any guesses? Well, would you like to know what the patient actually had? Intracranial nocardia. No myocardia, aka nocardia. So this was a nocardia case. And at some point, I might actually show you the nocardia as an unknown case in the future. Okay, so pay attention to your reports. Next feature, before we get to the cases, ambiguity is not your friend. Actually, we're still talking about reports. Ambiguity in your reports, whether you're diagnostic radiologist or whether you're a surgical pathologist, you don't want to be ambiguous. It can be dangerous to your patient. All right, let's look at reasons for molecular cancer. I specifically want to address ambiguity with respect to molecular signature reporting and interpretation. There are 3 big problem areas in terms of, you see this especially in the community hospitals. Incomplete understanding of the limitations of molecular techniques and platforms. Every molecular technique and platform has its own set of limitations, false positives, false negatives, just like every other technique, including the H&E, in terms of interpretation, or maybe the slide only sees hematoxylin. The end of the slide doesn't see hematoxylin. It's only eosin. It looks like necrosis because of all kinds of errors. Incomplete understanding. Lagging knowledge of recent major advances in brain tumor molecular alterations in classification. As everyone knows, the literature is just exploding, and this is in every area of surgical pathology, particularly in terms of our understanding of the molecular alterations, and it will be shaping majorly the next edition, the 5th edition of the WHO classification, WHO 2020, which I'm going to talk about in just a second. So lagging knowledge can also be a problem. But this is the one I want to talk about today, the 3rd one, and that's the ambiguous language used for test results. All right, let's look at ambiguity, just to define it, for those who may not be familiar. A word or expression that can be understood in 2 or more possible ways, all right? And that is not good in a report. All right, let's look at a referring institution report. Specimen is sent for IDH, 1p19q deletion, and MGMT. Okay, that seems a little bit loose. Immunohistochemical stains for IDH negative. I guarantee you that statement is completely inaccurate. Number one, how many types of IDH are there? That's isocitrate dehydrogenase. How many forms? There are 3 forms, IDH1, IDH2, IDH3. Which one was tested for? All right, everyone listening to me, I guarantee you, all of your cells are strongly positive for isocitrate dehydrogenase. It is a normal enzyme. All 3 are normal enzymes, and there are immunostains for the normal proteins, and those stains are going to be normal. So this is a crazy statement, right? There we go, IDH. Fish for 1p19q deletion is negative. I would prefer negative for co-deletion, but that's okay. We'll let it slide. MGMT by PCR negative. Negative for what? Negative for MGMT? I don't think so. Again, every cell in your body, except for the red blood cells that don't have a nucleus, don't have DNA, has mechanisms to maintain the DNA. Methylguanine methyltransferase, a repair enzyme. So I think what they really mean is negative for MGMT promoter methylation. That's what it means. And this would be one of those things. Well, can't you just read my mind? I mean, you know, we can use shortcuts. We can use slang, can't we? I mean, it's not like this is important or anything. It's just a patient. It's not a report on me. All right, how about this? The immunohistochemical stains are ARTX. Now, ARTX, I don't actually think it is. I think it may be ATRX. All right, it's performed at, and I've anonymized, and is interpreted as ARTX or ATRX negative. What does that mean, ATRX negative? Well, I mean, I assume that it's negative, just like the IDH. Okay, it looks like MGMT was done at a rough. Okay, but that's okay. That's okay. It was not them. It was not the referring. It was not the consultant reference laboratory that did the interpretation. Okay, here it is. IDH is negative. ATRX is negative. Do they mean the same thing? Or they interpret the same way? That means that there was no staining. Is that correct? So you put on the antibody. Let's say it's a typical brown stain, DAB, right? And there's no staining. So that means there is no reaction, which means the protein is not there. All right. Well, for ATRX, if the protein is not there, and if it's the ATRX R132H, which is probably what it was, even though it doesn't say that, that means that there is loss of the normal protein for ATRX. Therefore, I'm sorry, I conflated the IDH1 or 132H. So that's IDH. That was a separate issue. ATRX, the antibody directed against the normal protein. So if it's not there, if it's not staining, that's an abnormal result, right? Well, which is it? Or is it negative for being negative? Is it negative for negative? In other words, the immunostain showed a positive staining, which we're going to say it's negative because it's negative for loss. How confusing is that? Do you see the problem here? Okay, question. Is it possible to report the test results in a less ambiguous fashion? I think so. You know how I know? Because we do it every week. Take a look at this MD Anderson report. 20 outside slides. Left, right, look. Craniotomy. Diffuse astrocytoma, IDH mutant, WHO grade 2, KS67 4.3%. That's what puts it in the 2 range. Here we go. IDH1 protein status by immunohistochemistry, IHC, positive for mutant IDH1P R132H. That's the protein. So it's positive for mutant protein expression. All right, that is absolutely unequivocal. What about ATRX? Protein status by immunohistochemistry. Loss of expression in the tumor cell population. There would have been internal positive controls. The endothelial cells, normal neurons, normal glia, microglia, etc., would have showed the normal staining of the wild-type protein. That is unequivocal. P53 protein status by immunohistochemistry. Positive for nuclear expression, not cytoplasmic. Cytoplasm doesn't count, and it is strong and diffuse. All right, and sometimes I'll put in there 95% or greater than 95%. That means a 99.9% probability of a TP53 mutation, and this would be the classic triad of IDH mutant diffuse astrocytic disease. IDH1 mutation or IDH mutation could be 1 or 2, ATRX mutation, TP53 mutation. Okay, so everyone understand the problem with reporting this as simply not just ARTX, but ATRX negative. Try to be unambiguous. And this is not unusual. Okay, let's have the next challenge, neuroimaging challenge 301. Okay, I'm going to bump this up. Now, keep in mind, I want a diagnosis. I think everyone knows that when I say I want a diagnosis, what I want is the top entity in your differential. There is always a differential, even in things that appear to be pathognomonic from a single piece of data of the 8 Venn diagram spheres. And you think, well, it's got to be that. There's always a differential, and there are always mimics. So when I'm asking for a diagnosis, what I'm asking for you to do is use all the data that you have, formulate a differential, and tell me what is at the top of your differential. And of course, you're going, which means the statistically most likely diagnosis based on the data that you have. That's what I want to hear. Okay. All right. Let's try it. Ready? I'm gonna give you some information. 23-year-old woman. All right. So now you have age and gender. You've got 2 Venn diagram sphere data spheres. All right. Here it comes. This is good. I want to know a diagnosis. Actually, number 1 diagnosis of your differential. Here it is. And think about it for a second. 23-year-old female. This is the imaging. Okay, the first thing you're probably going to have to do is figure out, well, I would do the neuroanatomy. I mean, if you figure out what we're looking at, Sanjay Singh says medulloblastoma. Darshan Dwivedi says hemangioblastoma. These are good guesses. Sarah Cathcart says medulloblastoma infiltrate grade 4 and 4 with an Arabic number. Good job, Dr. Cathcart. I still have not seen what I'm looking for completely. Everyone's getting bits and pieces. These are good bits and pieces, but I'm not getting it. All right, what are the sequences? Anybody want to text those in? What sequences are we looking at? What is the left? What is the right? All right, Sanjay Singh, expert neuroradiologist, says this is a desmoplastic medulloblastoma. Dr. Singh is correct. I'm looking for one more thing. Actually, what is more important than desmoplastic? There's something that's more important because it's more specific. It's more specific. It will guide the clinicians to a greater degree. All right. Yes, Ann Kwan, holy moly, Ann Kwan was the first to come across with sonic hedgehog altered, with Dr. Dwivedi and Dr. Cathcart right behind her. I have to point out, Ann Kwan is our chief oncologic surgical pathology fellow at MD Anderson Cancer Center. Yes, it's sonic hedgehog driven. Now, how do you know that? We're gonna go through that. Now, it's not absolute. Could it be one of the other molecular receptors? Of course it could, but it's based on the data. Yes, Dr. Cathcart says it's hemispheric. It's not Burmian, it's not midline. Now, the sequences that you're looking at on the left is diffusion-weighted imaging, and this is bright. It's showing bright. That's restricted diffusion. The ADC map on the right, it goes dark. That's the control for T2 shine through. This is legitimate restricted diffusion. Restricted diffusion. One of the we'll call it a usage case, if you will. One of the entities in which that is seen is densely cellular small round blue cell neoplasms. And the poster child for that is diffuse large B-cell lymphoma. We stress it a lot. And this is not subtle. This is not subtle, little patchy restricted diffusion. This is in your face medulloblastoma. It is perfect for that. All right, so axial diffusion weighted image, or DWI, on the left, axial apparent diffusion coefficient, ADC map, on the right. This is 4+ restricted diffusion. Think small round blue cell tumor is clearly a mass. Okay. I was going to make it a little bit easier if no one had gotten it. And we have a huge brain trust attending this conference every week. And there's a lot of smart people who are going to get it. I was going to show you these images, more conventional, which are just the axial, coronal, and sagittal. You can see T1 post. The same thing, though, hemispheric localization enhancing lesion. All right, the diagnosis for this case was, in fact, medulloblastoma, sonic hedgehog, SHH activated WHO grade 4. All right, let's review medullo very quickly. Remember, we have 2 different ways that we can classify. The historical is the histologic classification, and we maintained that in the WHO 2016. What the position is, we should be reporting in our reports both the histologic subtype for those tumors that have subtypes. We used to call them variants, but the recommendation is what we used to call variants, we'll call subtypes, and we need to report the genetically defined subtype if we have it. All right, here's the histologic subtypes. This is classic medullo. You can see the homoryte rosettes. Sometimes there are no rosettes. That's fine. We call it the patternless pattern, right? Just sheets of small round blue cell tumor. There's desmoplastic. Looks a little bit like germinal centers and lymph nodes. This is take those same pale islands, stretch them out, make them flow, and that's medulloblastoma with extensive nodularity. The old name for this, the ancient name in the literature going way back to the time when I was a neuropath fellow, the alternative name was cerebellar neuroblastoma because the cells, the regularity, all of it looks so much like neuroblastoma. All right, and then finally, large cell / anaplastic. These were originally described as two different histologic variants, large cell medulloblastoma, anaplastic medulloblastoma. We realized then with more experience they overlap. We lump them together, usually a bad prognosis. All right, medulloblastoma genetically defined. First category, Wnt activated. All right, sonic hedgehog activated. Sonic hedgehog activated can be subdivided, importantly, into T53 mutant bad actor and TP53 wild type. All right, then medulloblastoma, non-Wnt, non-sonic hedgehog. Now you have to have data, to say it's non-Wnt, non-sonic hedgehog. If you don't have any data at all you have is histology. Oh, I'm sorry, and that can be divided in group 3, group 4. Right now, there's no difference in treatment, group 3, group 4, so it's not mandatory clinically. All right, and if you don't have any data, we'll call that medulloblastoma NOS, not otherwise specified. All right, so the diagnosis in our case is medulloblastoma, sonic hedgehog activated, T53 wild type. The reason why T53 wild type, this was based on actually the essentially negative P53 immunostain. I don't think that that's entirely accurate. I don't think you can make that statement because there can be mutations up to P53 which are biologically relevant that don't stabilize the protein. It's the positive predictive value. The positive predictive value of 99% of the cells showing nuclear localization, that would be predictive of TP53 mutation, but not the opposite. Anyway, this is what we're going with. All right, how do we know in this case? How did we know? How did we prove that this case? We suspected it based on the hemispheric localization. How did we prove it? Immunohistochemistry, surrogate markers, GAB1, positive tumor cell expression. Bam! In the context of a medulloblastoma, this is sonic hedgehog activated. We have a beautiful immunohistochemical surrogate marker for the SHH activated group. This is it. We are done, and that is accepted. YAP1 is also positive, all right, in this group. And then the P53 was very weak, which I just addressed, which was interpreted as a TP53 wild type. All right, and just to emphasize this, practical clinical classification using IHC surrogate markers. Here it is. I've referenced the paper, in the lower right, Brain Pathology 2015. Look at the sonic hedgehog category there going across, and you can see GAB1 strongly positive, YAP1 positive. The beta-catenin in the first column is only positive in Wnt, and that's nuclear positivity. I know it looks positive in the sonic hedgehog, but that's cytoplasmic. If you look closely, you can see that the nuclei are not staining. All right, and so it's only when you have the aberrant nuclear translocation, and that the nuclear beta-catenin in a medulloblastoma defines the Wnt subtype. All right, there we go, beautiful. All right, let's look at the molecular groups, and I know we looked at this, I think 2 weeks ago, we looked at this paper 2019. It really is nice. Here's the summary of Wnt, hedgehog, group 3, group 4. This is what we're talking about now, sonic hedgehog. Look at the first red box. You have the little thing is the infant, that's infancy. Then the bigger person is childhood, and then adult far right. All right, and note that the size indicates what it's more common in, and you can see definitely most common in adults. And then what's important, the key is anatomic location. Look at the 4 major molecular subtypes. Only sonic hedgehog has a very high incidence of hemispheric. Now, are there exceptions? Yes, there are exceptions. Are there overlap, like the tumor can involve both the vermis and the hemispheric? Of course there are. But when you have such a beautiful case as ours, do you need to see it? There it is. I mean, look at our case. Look at that imaging, and look at the diagram in the paper. Oh, it doesn't get any better than that for sonic hedgehog for hemispheric localization, and it's an adult, which is one of the most common types. You like that? Yeah. Okay. So that was the answer. That's why I wanted medulloblastoma, sonic hedgehog activated. I wanted to see that as the #1 entity in your differential diagnosis based only on the DWI and the ADC map. You see how that game is played? It's a very useful exercise. All right, and of course we would have to confirm all of that. We wouldn't make the diagnosis only from the imaging, but this is a sort of thinking process you should be going through. All right, let's review quickly molecular alterations in sonic hedgehog activated. Now, the one thing they all have, 100% of SHH activated medullas have sonic hedgehog pathway activated. Guess what? Virtually none of them have a mutated or activated, sonic hedgehog. It's just a pathway. All right, so look at the commonly, I've underlined in red, mutated or deleted. It means lost SHH genes. Patched is number 1, 43%. SUFU, suppressor of fused, 10%. That's lost, all right, lost. How about activating mutations? Smoothened, 9%. Amplification of GLI1 or GLI2, 9%. MIC-N, 7%. All right. In addition, recurrent alterations of TP53, we address that. Very important. All right. Whether it's wild type or mutated. PI3 kinase pathway. I think we had a case of that last week. TERT promoter mutations are also found in overall 39%, almost 40%, and nearly all adult sonic hedgehog cases. All right. Frequently in the cytogenetic events, so also 9, which is patched, and 10, which is SUFU. And these are just, look, here's the point. I've underlined the percentages. Now, what these are called, these are the variation. Many times in many tumors, it's a pathway that is dysfunctional, a pathway which will have many members and many regulators, positive and negative, of the individual members of the pathway. So you could imagine having 100 different molecules that potentially, if altered, either activated or suppressed, removed, delete, would activate the pathway and result in the end result. With other tumors, it's one thing, ATRT. I mean, that's basically it, right? It's a one gene, single gene. With others, it's more complicated. Now, you always need to be aware of the pathways, and maybe with your case, the next case you see, you're going to say, oh, this is a classic sonic hedgehog activated medulla. Everything fits, and it's just, but I'm not seeing one of these major ones. Well, go to the pathobiology. Look at the pathway. Look at the positive and negative regulators. Is one of those genes altered? All right, now that's what you need to be aware of. Okay, and again, the importance of the surrogate markers. Most of this we can do for medulla. We can do 99% of it without having to have genetics or genomics. Isn't that great? That is great because there's a giant world of patients out there that do not have access to molecular characterization, but they do have access to imaging, they have access to H&E, and then a lot of them have access to immunohistochemistry. So we try to have immunohistochemical markers whenever possible, and I'm going to address that again in just a minute. Okay, new conference feature. Could it be enough? Yeah, 2 new conference features in one conference. All right, this is busy. Okay, I'm going to call this the big news of the week. I'm not sure when we're going to have big news again, but we had some really big news this week in oncologic neuropathology or neuro-oncology, and it's big for everyone. Do you know what that big news was? The CIMPACT Now Update 6 is out, all right? EPUB before print, it is out. Here we go, Brain Pathology, April 19, CIMPACT Now Update 6. Update 6 is the meeting report. See that highlight, meeting report of the CIMPACT Utrecht meeting on tumor classification and grading, which was held to inform the creation of the WHO 2020. Now, 2 areas were focused on, 2 broad areas at this meeting, and this is the report of the meeting. New entities, all of these entities that have come up in the literature since 2015, because the WHO 2016 really, most of the data was up to 2015. So we're 5 years. We are 5 years down the road from WHO 2016. A lot has happened. So potential new entities, we have to look at, is the data mature enough, solid enough, reproducible, multiple studies, multiple labs, et cetera, for warrant incorporation. And secondly, diagnostic principles. And we need to have a look at the way we're naming tumors because we can clean it up a bit. All right. So thinking about principles, the CIMPACT Utrecht meeting established the following principles and hope that they will guide future efforts. And they will, because most of the people that participated in the conference in Utrecht are going to be the same ones, plus a whole bunch of others, about 100 other people that will be involved in writing the chapters and creating WHO 2020. All right, first of all, types and subtypes. This is a minor thing. Everything was addressed. We used to, prior CNS tumor classifications use the terms of entity and variant. So we'd have an entity and then we'd have variants. We're going to come in line with all of the other WHO Blue Books, and we're going to call them types and subtypes instead of entities and variants. All right, a type is defined neoplasm in which multiple parameters, clinical, anatomic, histologic, and or molecular, differ from other types, like myxoid glial neuronal tumor, which is a septal-caudate DNET. A subtype is a variant. Well, look, you can't get, I said we're going to get rid of variant, and here it is, variant. All right, can't get away from it. A variant of a type in which a single or a couple of parameters, maybe only clinical, only anatomic, whatever, suggests it differs from other subtypes and makes it desirable to recognize. For example, methylation class 1 and 2 types of diffuse leptomeningeal glioneuronal tumor would be an example. All right, approaches to tumor categories: pediatric type glioneuronal tumors and ependymomas. Okay, this is a major area of dispute, controversy, all these different names in the literature, and I'll tell you why. So classification of pediatric IDH wild type and H3 wild type diffuse gliomas, illustrating the principle of a matrix approach for reaching an integrated tiered diagnosis. All right, let's take an example. What does all that mean? It sounds like gobbledygook. Let's just take pediatric diffuse gliomas. Pediatric patient, it's a diffuse glioma, it's IDH wild type, and it's H3 wild type. So those are not the drivers. Those are not relevant. All right, we can define it genetically and histologically. Genetically defined. Look at all these different alterations: MIB, MIBL1, FGFR1, etc. All of those have been reported, and they're all diffuse gliomas. What they can look like histologically, look at the bottom part. They can look either like astro or oligoastro, etc. So the histology is not specific to one of these molecular alterations, and these are important alterations, some of which may be targetable. All right, and so here's an example. Look at the very bottom, integrated diagnosis. This is how one example might look. It's in the cerebrum. The integrated diagnosis is diffuse astrocytoma, MYB altered. The histopathology, the H&E, looks diffuse astrocytoma. The grade would be a grade 2, or that's Roman. We're going to be moving to the Arabic, so 2, see text coming up. Molecular information, H3 wild type by sequencing, MYB, PCDH8 fusion by sequencing, MYB rearrangement by interface FISH. Isn't it interesting that they're actually putting in the technique by which these things were determined? Guess what? I have been doing that at MD Anderson for, I don't know, probably maybe 10 years now, certainly since WO 2016, all right? Possible future classification for pediatric type glioneuronal tumors, the same thing, all right, for these pediatric glioneuronal, right, not just diffuse glioneuronal, genetically defined. These are all of the different molecular alterations in the literature, multiple papers which have been shown in the pediatric glioneuronal tumors. What do they look like histologically? They can look like astro, oligo, angiocentric glioma, ganglioglioma, DNET, RGD, all of these different things they can look like. And here's the problem. It's not a one-to-one correlation. For example, all of the ones that look like astrocytoma and H&E don't correlate with BRAF V600E or MYB altered. It's like a mix and match, if you will. So here's the proposal would be, again, that we report both. You report the H&E appearance, that would be the histologic subtype, and then there would be the genetic signature. That is a proposal. Let's wait and see how it shakes out. You know, pediatric neuro-oncology is remarkable for the explosion of knowledge over the last 5 years. It is truly amazing, but it is very complex. And because the tumors are rare, it's hard to put together enough of them to be certain when we make the calls. But that's what's going on right now. All right, methylome profiling was addressed. The technique was addressed because it's such a hot thing. There's two conclusions. Methylome profiling has been shown to provide powerful information for classification and diagnosis. Go to the bottom. Most tumor types and subtypes can also be reliably identified by other techniques. For example, histology and defined genetic alterations. All right, and that's really good that is true, because methylome profiling is a very esoteric technique confined mostly to major medical centers, to tertiary care academic institutions. It is not widely available in underserved countries, and the WHO classification and appropriate treatment of our patients in every country is important. So this is a good thing. All right, look at it. That says Arabic versus Roman numerals. look at this. I'll let you read it at your own time, at your leisure. Bottom line is we're going to Arabic numerals. All right, new entities and name changes. Let's look at this. For each possible type, subtype, the groups, these are the study groups, the focus groups which address the different areas. Had to decide whether the lesion was one of these from table 1. Newly recognized type, subtype, brand new tumor with all this data that we need to recognize that is not recognized as an entity, a type or subtype in the WHO 2016. Existing type where we need to change the name for various reasons. Existing type where we don't change. Now, this is not every things like no meningiomas weren't even discussed. These are tumors for which we felt like we might want to include the molecular signature, but it was decided no, we don't need to. And finally, lesion sub, how do you say that? Judice. Any guesses? You know what I heard a lot of in Utrecht? Judica. How do you find out what's right? None is Latin. The original speakers of Latin, they're all dead. They're gone. But there are accepted rules, and it's important that you know, like, what is the standard? And there are educated people who study Latin, believe it or not. They're into our lives for a career, and it's out there. All you have to do is go to a dictionary, and you see the pronunciation. We're going to look at it. All right. That subjudica means lacking sufficient evidence. All right. Now look at this. This is the entire list that was looked at. All right. Let's go through them category by category. We're going to go pretty quick. Newly recognized types and subtypes. Do we incorporate these? All right. The first three, glioblastoma, IDH wild type, and IDH mutant, and pediatric. Pediatric we've already addressed. I already showed you that table. The other two we'll look at in a second. All right, diffuse glioma, H3.3, G34 mutant. Do you remember in WHO 2016 what one of the revolutionary things about it was? For the first time in WHO 2016, for the first time in brain tumors history classification, we included a molecular signature in the name of the tumor, all right? And it was diffuse midline glioma, H3K27M mutant. All right, that was the first. Well, we did not include the hemispheric equivalent of that, which was diffuse glioma, H3.3 G34 mutant. Well, we're fixing that problem. It's going to be official. All right, high-grade astrocytoma with pyloid features. This was felt to be mature enough to warrant inclusion on its own as an entity. And there's by the way, in the actual paper, we don't have time today, there's an entire little section, multiple paragraphs on each of these entities I'm showing you. All right, so you can read astroblastoma, MN1 altered. Guess what? Astroblastoma gets a formally codified molecular signature. MN1, what gene is that? Anybody know? What's the name? Meningioma 1. All right? Has nothing to do with meningioma in this context. Diffuse left neuronal type, myxoid neuronal tumor, that's the septal-called ADNET. And then look at these two, polymorphous low-grade neuroblastoma with young, that's plenty, and multinuclear and vacuolar neuronal tumor. All right, both of those go together. Put them together because they're similar and interesting. Who discovered those, by the way? Who discovered them? Jason Hughes, MD Anderson Cancer Center. Yes, when he was at Memorial Sloan Kettering. Yada, yada, yada. Guess what? He's at Anderson now. That's all that counts. Okay, look at ependymoma. All right, we're in WHO 2016, all the ependymoma diagnoses were ependymoma, anaplastic ependymoma, subtypes, et cetera. Okay, and then and spinal ependymomas were just ependymoma, et cetera, et cetera. We're going to divide them now first by anatomic category. Posterior fossa ependymoma, supratentorial ependymoma, spinal ependymoma. That's one thing. That's how they will all start. Then we will add molecular signature. And these are the four new molecular signatures. We already had the REL-A. That's why it's not here. It's already in the classification. And then finally, some just odds and ends at the very end. All right, existing types of modifications, choroid glioma. What's the name that you know it by District 2016? Choroid glioma of the third ventricle. We're dropping anatomic location where it's not necessary. Supratentorial, REL-A fusion positive. Yes, see, we've added supratentorial to ependymoma, REL-A fusion positive. All right. Papillary glioma, all of these, most of these were have dropped anatomic location. All right, let's look at this again. I thought I had this earlier. Okay, here are the lesions, which we'll look at now. I want to talk, this is the $10 word of this Latin phrase. It's the $10 word of the day. All right, we can call it the $10 Latin phrase of the day. Here it is, a long, uncommon word or phrase used in place of a shorter and simpler one with the intent to appear sophisticated. And let me tell you, most oncologic neuropathologists really, really, really want to appear sophisticated. I'm sorry, they're just not. Anyway, yes, that's where we get it from. How do you pronounce it? Well, let's go to the Oxford UK Dictionary, all right? And you can see here, anytime you have that symbol, you just click on it, all right, and it's going to tell you. And then you can see the pronunciation. Now, those symbols, that's standardized. All those symbols are standardized. Everybody see the question mark right after pronunciation? You click on that, it will give you the entire guide with normal, regular words that show you what each of those means. But this is internationally standardized. All right, now what does it mean? Law, under judicial consideration, therefore prohibited public discussion. What it means is the judge or judges, us, are still looking at it, and we're not sure yet if it should be. All right, look, this is one of the other sites for Oxford Dictionary. Look at the pronunciation here, which does not use the standardized international system. Subjudice. 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 I don't think I actually heard that in Utrecht. Subjudice. And see, it's very easy. You have to be curious. Don't just accept someone's word. Well, that's the way it is in the departmental website. WebEx. How do you actually spell WebEx? Is it capital W, lowercase e-b-e-x? Is it capital W, capital E? Is it capital Web? Is it capital W, lowercase e-b, capital E-x? You know, why don't you go to this is owned by Cisco company, all right? Full disclosure, I own Cisco company. No, actually I don't. All right, the answer is go to Cisco, go to their website and see how they spell it. That would be a remarkable thing, wouldn't it? Try that. Okay, here we go. What are the lesions that we're not sure of? Diffuse glioma, FGFR, TAC fusion positive. Man, that's really close to my heart. Remember, that's the one that we can get an indication from the H&E. It's going to look oligo-like, you know, round cells, halos, microcalcifications, perivascular pseudorosettes, all of that. But it's clearly not oligo. Think maybe an FGFR TAC fusion glioma, but the feeling was it's not distinctive enough to pull the trigger. Maybe that'll change. All right, and then here's the rest of the list. We're not going to look at these. You can read. You can read. These are all the. See all the molecular signatures. These are all entities, including look at the infants. All right, all of these that have molecular signatures, which we have discovered with the explosion of next generation sequencing, methylome profiling, et cetera. All these other platforms, omic platforms, which the collective wisdom says they're not mature. The data is not mature enough, certain enough to incorporate, but we're going to be following, okay? All right, now just a few highlights and we'll be done with this, but I thought it was important enough just to do that. Just a few, very few highlights. This is the diagnostic criteria for glioblastoma IDH wild type. Now look at table 5. Let's just go to table 5. Here's the bottom line. The bottom line is, what do you need? What do you need as a pathologist to make this diagnosis, glioblastoma IDH wild type? What do you need from the tissue to render this diagnosis? Now, keep in mind, this is the most common type of glioblastoma. This is primary glioblastoma. Older adults, 85% of glioblastomas are this, not the secondary IDH mutant. What do you need for it? Well, okay, first of all, it has to be IDH wild type. It has to be diffuse. It has to be an astrocytoma. All right, and this is for adults. It has to be an adult. And it has to have microvascular proliferation, right? That was a critical feature. Or necrosis. We've known that for a long time. That is the gold standard. Here's what's new. Or one of the following. And if there's more than one, that's fine, but you only need one. TERT promoter mutation at one. It'd be good to check to make sure it's one of those canonical sites that actually blocks the promoter, blocks transcription. EGFR gene amplification. That's high-level amplification, not just polyploid. And or gain of 7, loss of 10 chromosome copy numbers. All right, it has been, look, the point here, remember we had the C-Impact update, we gave this long, complicated, diffuse astrocytoma, IDH wild type with molecular features of glioblastoma, WHO grade 4, remember that? We're going to get rid of that because it was preventing patients from entering the study. Now, if you have one of these 3 features, we can call it glioblastoma IDH wild type. Now, look, I'm saying this. Hang on. Let's take what do they call it? Let's just take a quick break. Okay. Everything I'm presenting in the C-Impact Now Update 6, these are recommendations from the committee, which we hope will inform the group that actually creates the 5th edition, right? But the overlap in terms of the authors of this paper, et cetera, is 100% of those that will be involved, and there'll be more voices as well. So what I'm saying, this is a prediction of the future, right? Everyone understands the context. All right, definitions for IDH mutant diffuse astro, we've covered this before. It was in one of the C-Impact. Astro IDH mutant, WHO grade 2. Notice, we're not calling it diffuse astrocytoma IDH mutant. It's astrocytoma IDH mutant. And the reason is, if you go all the way up to look at the grade 4, does it say glioblastoma IDH mutant? No. It says astrocytoma IDH mutant, WHO grade 4. All right. Now, you certainly could make an argument for calling it diffuse astrocytoma IDH mutant, but the key was to get rid of glioblastoma, reserve glioblastoma for IDH wild type, so it retains that meaning and intent. Now, the other big thing, as you saw through all of these, was look at this. Mitotic and CDKN2AB not present in grade 2. CDKN2AB homozygote lesions absent in grade 3, but if they are present, You do not, listen up. You do not need vascular proliferation or necrosis in infiltrated diffuse astrocytoma, all right, which has the CDKN2 homozygous lesion to bump it up, IDH to bump it up to a grade 4. All right, that's the big thing to pay attention to. All right, suggested name changes. A lot of these, as I mentioned, look, we're getting rid of choroid glioma of the third ventricle. Of the third ventricle is gone. Multinodular vascular neuronal tumor of the cerebrum is gone. These are the recommendations. Some we need to keep it like extraventricular neurocytoma. That's really needed to contrast it with central neurocytoma. So extraventricular is a location. We need it. Okay, and then the ependymoma supratentorial, we're going to keep that because we're going to divide the ependymomas by name, supratentorial ependymoma, infratentorial, or I think posterior fossa, infratentorial ependymoma, and then spinal, all right? Genotype, no. None of these, it was felt needed a genetic signature. Man, that was a lot, wasn't it? Okay, I think I'm just going to include that as a warm-up. Again, the paper is out there. You can read it for yourself. Now, guess what? There's a lot more information about everything that I just addressed than I was able to cover, right? It would probably take 3 hours to do it justice, but the paper's out there. I think you have a really good feel for what's there. It's a very exciting time. And by the way, let me just say before we go to this first patient, let me just add that we are fully on course to create this 5th edition of the WHO, probably WHO 2020 is what it's going to be called this year. There were significant disruptions by COVID-19. The in-face meetings, there would have been 2, will not be able to be held. But the online, I mean, everyone is geared up for this, and it is proceeding apace. All right, so that's an update. Okay, let's take our, we're ready for the first case. Patient number 1. I know there's only, about 15 minutes left. That's okay because I only have 2 patients. So patient number 1, this is a 2.5-year-old. That's 2.5-year-old male. There we go. And you can see the sequences here. These are both sagittal sections. All right, it's going to be a T1 on the left, T2, native T2 on the right. You see the CSF, very large tumor filling the 4th ventricle. All right, here we have coronal on the left. These are T1 with contrast, coronal on the left, sagittal on the right. 4+ irregularly contrast enhancing. All right, and then I want to show this. These are lower cuts, axial cuts. All right, I want to ask a couple of questions. What is the blue arrow pointing to? What is that structure? What structure is that? I'm going to take a break. I'm going to have a little coffee here while I'm waiting for someone to type in what that is. Okay, we've got Dr. Cathcart saying pons. Yeah, it's very close to that. All right, it's very close to the pons. It's at the junction of the pons and the medulla. All right, Dr. Trivedi, same thing. Dr. Susanna Collier, one of our outstanding neuroradiologists, medulla. All right, now it's actually the medulla oblongata. Have you ever heard if there's an A, there has to be a B? Why would we say medulla oblongata if medulla would do it? The answer is because historically it was not the only medulla in neuroanatomy. What's the other medulla? I'll actually give some sort of a prize to whoever can type in right now the other medulla. Originally it would have been said in Latin. I'm fine if you want to use English. There was a medulla oblongata and a medulla. Dr. Collier got it, but you Dr. Collier, yes, the special award goes to Susanna Collier, neuroradiologist. She said spinal cord. What I wanted to hear, yes, you're correct. Why? I wanted to hear medulla spinalis. It is medulla spinalis, all right? Now, if I wanted to be mean like I am to the neuropathology fellows, I would say you only get a 50%, which is a high F, but I like to be very kind to our neuroradiology colleagues. So full credit for the English. Yes, medulla oblongata, medulla spinalis. Now, I think you guys are trying to distract me. So that is the medulla. What is the point, by the way? The point is I'm going to ask you anatomically, if that's the medulla or it's close to the pons, what are we looking at here? What are the arrows? What neuroanatomically are they indicating? And what is happening at this site? And how does it help us? Yes, Dr. Trivedi, foramen of Luschka. See, Dr. Singh was close. He just simply said Luschka. All right. inferior cerebellar peduncles, close. This is, but see, how would that help us? If it's a peduncle, this is the tumor growing out of the lateral foramen of Luschka. L, lateral foramen of Luschka. M, median. M, Magendie, median foramen of Magendie. Or if you're Texan, Magendie. Okay, so yeah, so what the tumor is growing out through the lateral foramen of Luschka. All right, well, let's look at his side. I have it. This is a real case, real live case. This is the touch prep. What do you think? Shedding a single cells? Maybe medulloblastoma, single cells? This is an outside case, by the way. There we go. Okay, what do you think? They're kind of weird looking cells, aren't they? Yeah. Dr. Cathcart says, ha ha. Yeah, these are red blood cells. Look, there's a problem. This is a true touch prep on an intraaxial lesion, a ventricular lesion. Okay, I'm fine with doing a touch, but if you do a touch on anything except for a known shedder, what known shedders are like the small round blue cell tumors that have no junctions and no long processes. Medulloblastoma, sure. Pituitary adenoma, always. Lymphoma, absolutely, sure. Most necrotic, metastatic tumors, metastatic carcinoma, metastatic melanoma, yes. But on a suspected primary CNS tumor, fine, do your touch prep, but you're likely to get red blood cells. And a few other air-dried, whatever. Most of those are going to be white blood cells. I see at least one neutrophil there. You've got squat. You've got nothing. Do a smear also. Listen, do you know there actually is no law, and I believe this is not just the United States. I believe it's actually international. There is no law against doing two types of cytologic preps when you're called for intraoperative consultation. Do the touch, then do a squash, do a smear, do a drag. Do two. Do whatever you have to do to get the tumor on the slide. And there was no excuse not to have a beautiful smear of this tumor and nail that diagnosis of ependymoma right off the bat. These are red blood cells. All right, look at the frozen. Okay, fine. What's the feature we see here that says ependymoma? Yes, Arsene Trivedi, ependymoma. What's the feature? But the question was, what was the feature? And the answer is, that's okay. Yes, Dr. Trivedi, perivascular pseudorosette. There we go, higher power. Everyone see the blood vessels surrounded by those anuclear zones? They're easiest to see in a, quote, cellular ependymoma, which has been eliminated. It used to be a formal variant, believe it or not, it was. But it's just areas of dense cellularity. They're easy to see. When the cellularity, listen, when the cellularity of the ependymoma is sparser, lighter, it can be somewhat difficult or more difficult to spot the pseudorosette. But you can usually find them. Of course, the chromatin pattern, et cetera. Okay, here's the EMA, epithelial membrane antigen. What is the pattern that we are looking for EMA? What's the pattern we're looking for? And the answer to the question is perinuclear dot-like. Yes, Dr. Zainab Harb got that right, dot-like, and ring-like, and rings. Dots are going to be most common, and then after that, dots and rings. And the rings are the intercellular junctions, right, and all that stuff, right. What do we see here? All right, what we see here, this is 20X because I don't have the slide scanned at 40. It doesn't matter. You don't see anything more at 40. Yes, Dr. Trivedi, you see nada, as in day, nada, de nada, nothing. Does this mean that this tumor is not an ependymoma? No, of course it's an ependymoma. Dr. Trivedi says, nope. I tend not to like nope, yep. Dr. Harb, check the control, absolutely. Now, here's the thing, but the point is, Dr. Trivedi says, sheesh. Okay, that's enough, Dr. Trivedi. Here's the point. Yeah, no, Dr. Cathcart, I will accept yup, Y-U-P, but only from Dr. Cathcart, because that's how she was raised. Okay, here is the point. You're welcome. The point is only about maybe 20 or 30%. Listen, only maybe 20, maybe 30% of ependymomas will show the dot-like. It doesn't matter. We do it because it's reinforcing. If it's negative, it doesn't mean anything. This coach was showing. Okay, here's the GFAP. You can see the accentuation around the blood vessels. In other areas, look at this. It was almost solid. It's quite variable. Sometimes it's almost negative. And here's your next quiz question. What's the antibody? ERG? Okay. Yes, Sergio Pina, Oviedo, ERG. CD34, ERG and CD34, CD34 from Dr. Harb. Quick question. This is an obvious ependymoma. It was strongly suspected because it was a plastic ependymoma on the pre-op imaging growing out through the lateral foramen of Luschka. It was strong, yes. Dr. Giselle Lopez, neuropathology fellow, yes, Dr. Lopez is correct. H3K27ME3. Now let me finish my lecture. The lecture was, why would I order an ERG or a CD34 or any other endothelial marker on a tumor that I already know is an ependymoma? I suspect it from the imaging, and I know it from the perivascular pseudorosette. Why would I order that? To look for vascular proliferation? Dr. Sergio says for fun? No, Sergio, for profit, for money. All right, clearly, Dr. B is an academic, not in private practice, just doesn't get it. Okay, yes, look, the point is, this is huge, higher power. The endothelial cells, and if we had bigger fields, rare other normal cells would be positive. The endothelial cells are positive. So what that says is that this is a normal nuclear marker. That's what it says. See this one? And the tumor cells, all the tumor cells are stone cold negative, and it's an ependymoma. This is an antibody directed against the trimethylation signature, all right, of H3K27 residue. All right, here's the papers. The current consensus on clinical management of cranial ependymoma. And here you can see, let's just talk about ependymoma. All right, look at this, supratentorial ependymoma, rel A, supratentorial ependymoma, YAP1, posterior fossa ependymoma A, posterior fossa ependymoma B. That is going to be the classification that I mentioned, I think, in the new 5th edition WHO 2020, right? Okay, immunohistochemical analysis of H3K27 ME3, that's trimethylation, demonstrates global reduction in group A. So this is an immunohistochemistry diagnostic technique. One paper? No. Here's another one. Lowered H3K27ME3 and DNA hypomethylation defined poorly prognostic. That's going to be A. Absolutely. All right. Here's the MD Anderson surgical pathology report. Outside slides from which one special study, immunohistochemistry for H3K27ME3, was performed. Brain, fourth ventral, craniotomy, posterior fossa ependymoma. I'm using the WHO 2020 nomenclature already. Posterior fossa ependymoma. Pediatric type, in parenthesis, PFA, which was posterior fossa type A. That's what that stood for, WHO grade 3. That actually was elevated mitotic activity. I didn't show you. Got it? All right. And look at this. Also in the diagnosis section, H3K27ME3 status by immunohistochemistry, loss of nuclear trimethylation mark in tumor cells. Bam, done. Do we need methylation profiling? No. All right. And it's actually in, this is actually in the, I believe that is, yeah, it's in the, Update 6 that I just showed you discussing this, is that the diagnosis can be made either by methylation profiling or by demonstrating reduction of the H3K27 methylation profile, which is wonderful news for all those institutions and countries which have immunohistochemistry, but they don't have a significant molecular capability, much less have methylation profiling or be able to afford to send out for it. All right, and then let's like typical MD Anderson report. Look at the comment. Always start with the H&E. H&E stain section showed glial neoplasm, characteristic morphologic features, ependymal differentiation, yada, yada, yada. Molecular signature determination performed. That's what they show, confirming the diagnosis. And then here's pediatric type posterior fossa ependymoma. Arises primarily in infants and young children 3 years of age and younger. Remember, how old was this patient? 2.5 years. Bam, perfect. And exhibits a prognosis that is worse compared to that of adult type. All right, posterior fossa ependymoma or PFAB. Got it. Okay. All right. I tell you what, we are right at 1:58. I'd really like to keep us. I know people have other obligations. I have one more case, but you know what I'm going to do? I'm going to save that case just like I did last time for next week. That way we end on time. Thanks to everyone for attending. There would be no conference without you. Much appreciated, and I hope to be back with you again next week. Listen, one heads up. I think I mentioned that Dr. Vince Kumar, a neuroradiologist, has been asked to head a national international functional MRI conference, and guess what time they have chosen to hold that conference? Fridays at 1, our slot, my slot, our slot. So I'm going to have to think how to deal with that. We may be moving the conference either to 10 a.m. on Friday or to 2 p.m. or 3 p.m. And if we move to 3 p.m., I got to tell you, I'm going to be calling it Oncologic Neuropathology Diagnostic Medicine Happy Hour. All right, if you want to vote for a time, appropriate time, please shoot me an email. Other than that, thanks to everyone for attending. We're at the end of our hour, and hope to see you next week.